Hi, everybody. This is Erica Mello and Susan Clinton, and welcome to podcast number 92. And we're clicking on down to 8 more episodes, and we're at 100. And speaking of, we are on our mission, as you know, to get 100 testimonials before our 100th episode. So please, if you have not done so, please write us a testimonial on wherever you listen to podcasts. iTunes is where we get the most testimonials. So if you are an iTunes user, Apple Podcasts, please leave us a testimonial if you have found value with our podcast. We would appreciate that immensely. It really helps us. Once you hit that magic number, it helps us get found more easy, I should say. So now, thank you in advance to our loyal audience. And we also want to thank everybody and thank our new members of our second round of our clinical mentoring program. And
Absolutely.
we want to thank them for signing up. And we are in our sort of second week, and we are enjoying it immensely. So thank you to all of them as well. So I will briefly just do the intro here briefly for this patient. Is a patient of mine who we don't talk a lot about knee pain. I mean, we do, but I think that this is not straightforward, but it's a topic that I think is overdue, and it's basically about an older gentleman of mine who had basic knee pain. It's pretty straightforward, medial knee pain due to an overaggressive personal trainer. So Susan and I, discuss other possibilities for this man's medial knee pain, and as you know as well, is it always the knee? Is the knee the driver? Sometimes it is, and sometimes it isn't. Hope you enjoy it. Hi, everybody. Welcome to episode 92, and I'm here with my lovely co-host, Susan Clinton. How are you, Susan?
I'm well, Erica. How are you?
I am good, thank you. We're going to get right to the episode. As I mentioned in the intro, we don't talk about knee pain a lot. In patients with knee pain. So I think that this is it's about time that we sort of discuss it a little bit. And I think that, which is why I chose this particular patient. So, I'll just start basically. He's a patient I've known for a while. He's an older gentleman in his 70s. He came to see me some years ago with a right shoulder problem and fairly active, works out with a personal trainer. Not one to linger in physical therapy. He just comes and does his thing, and we get him better and he goes. He's not one to sort of be a lifer, so to speak. So the last time I saw him was at the end of December 2020. And so his main issue was right medial knee pain. That was somewhat of an acute onset. I don't tend to see a lot of acute patients, but since he was an existing patient, he came in, and it was pretty much about a week and a half before he came in to see me. Walking was the most aggravating for him. And grant you, wasn't walking a lot, here in New York and at the time, but he did go and take an occasional walk around Central Park with his wife. And so he was fine in the morning when he got up, no problems at all.
Mm-hmm.
He had no his knee wasn't swollen. He said he wasn't taking any ibuprofen, he's not a real, ice medication kind of a guy. So he basically believes, when I questioned him, that, I said, what started this? And he works out with, as I said, a personal trainer, and can be very aggressive. Yes, he's in his 70s, but, as Susan and I, we talk about, there's no reason why you can't load these patients, right? Load these individuals. And she did. So what happened is he said that he did an egg roll, which is like, I guess, a rollover. I'm not sure why he was doing that, and then he kind of jumped in a squat and then jumped up. So rolled over, got into a squat, and then jumped up. That's how he described it to me. And then the next day, his knee was pretty sore. Okay. He denied any, sort of paresthesias, numbness giving way, et cetera, et cetera. Lying on either side, side lying left, side lying right, bothered him. So it was his right knee. Walking was worse. Sitting is fine, obviously. So side lying both sides.
Mm-hmm.
And then I had him go sideways. So when he went to his left, leading with the left, going sideways, that bothered him. When he was leading with the right, it did not. Let me see if there's any other significant subjective. Since I've seen him before, he went on a new statin recently. That always raises my radar when I hear that. But other than that, he was fairly pretty healthy. No illnesses. The only other injury that he had was this same side right shoulder. Other than that, no other issues like that he's seen me for. Okay. He works out with his trainer twice a week. And when I treated him for his shoulder, once again, I had to get the trainer, and say, you need to sort of tone this down a bit, because she was super aggressive. And I'm not saying that that's a bad thing, but both of his injuries that I've seen him for have been because of an aggressive personal trainer. So do you have any comments on that, Susan, or should I keep going?
Well, a couple of things. Number one, his right shoulder. Is he right-handed or is he a right shoulder sleeper?
He is a side sleeper either side, and he is right-handed, yes.
Okay. He just recently went on statins.
That's what he said, yes.
Mm-hmm. So he doesn't really know how, did he have immediate knee pain after the rollovers, squat, jump up kind of sequence? Kind of sounds like he was doing MMA stuff.
Yeah, right. Exactly. Exactly. Not immediately, but the next day.
Okay.
Or the day after, like a 1 to 2 day post.
That also kind of rings a little thing like, okay, so does he really actually have a knee injury? Like, is it something going on in the knee, especially because laying sideways left and right bothers him? It's just kind of, if it takes a step out. My thing is I always kind of wonder, especially when we get into individuals that are a little bit older, is it a little bit of kind of almost neurogenic, like spinal stenosis that can act like an inflammatory process around a joint, which is weird. I mean, it does that quite often. They x-ray the knees, and of course there's degeneration there, but the knee, you could probably mobilize that knee, and I don't know. Yeah. It's going to be interesting to see what you find in your because I would be kind of like thinking, where's this coming from? I mean, I realize that his knee hurts and it's definitely, being magnified there, that's where it's being expressed, but it kind of also makes me wonder, what else. And so my other question is, how much is he walking? Does he have pain when he walks? Does he get worse when he walks?
Yes, he's pain when he walks, and it gets worse when he walks.
And better when he sits down?
Yes, and better in the morning too.
Yeah.
Not stiff in the morning at all.
Yeah, that's the part that makes me kind of start thinking about like a spinal stenosis type of
lateral
or central. I don't know. But I just wanted to kind of throw that out there as a differential, that this is why you and I never really look just straight at the knee. We also try to see what else may be driving this, because he may be pulling to one side or another side to relieve anything that may be happening kind of centrally.
Right. And it's interesting because when he did his side step to the left, I'm just doing it here, did he, go into a little bit of a side bend to the right? Who knows,
right. Did he allow it to stretch to the right?
Correct.
He may have sunk to the right in order to kind of step to the left, and that made it worse.
Right.
So stretching and lengthening probably both irritate him. Walking is the big one. And then when they sit down, if it feels better, then it's like, because oftentimes when you have something intracapsular in a knee, even when you sit down, it's not comfortable.
Yeah. So interesting. I assessed him, and I just said, let's just do a body twist. Let's stand and do a body twist. Right. I'm looking at the feet, I'm looking at the knees. So he stands, he does a body twist to the right, it's symptomatic, right? So you're like, it could be spinal, knee, it could be whatever, right? Then he goes to the left, and he's like, that's not so great either. And then, so I said, okay, let's just keep doing it. Let's just keep doing it to see if it's consistently worse. And so the more he did it, it didn't get worse. It maybe got a little bit better, but it still was like somewhat symptomatic. So I look at the feet, I'll look at the feet. Do they pronate and supinate in the right direction? If you're going to the right, I'll look at if the right foot supinating, is the left foot pronating. I'll look at that quickly. I'll look at the knee just to see if there's any kind of, standing that right knee was in flexion. It was not in extent. It was basically, he had the right knee bent, the left knee straight, like a normal, not hyperextended. Mm-hmm. So when he did a body twist to the right, yes, he's not going to get that tibial external rotation because his knee is flexed, right?
Yeah.
So you could either go, okay, well, it could be the knee, it could be the foot. It could be the back.
Why is he holding the knee flexed? Well, obviously it's more comfortable in flexion, or he wouldn't be doing that. Or is that protective response of the hamstrings to what's going on, Correct. And so it could be that the knee is not bad being straight. It's just that the protective response is holding it flexed.
Correct. Exactly. But the thing with, if you have a patient who's got significant OA of the knee, that morning is very stiff in the morning. And he doesn't,
it doesn't follow the pattern
doesn't follow the pattern at all.
Mm-hmm.
So
usually they're a little bit stiff in the morning, and then they take a shower and they move around and they feel great until later in the day.
Yes. And I'm thinking, okay, going back to the mechanism of injury. Okay, you're doing an egg roll, you're rotating, you're going into a full squat, then you're jumping up. How do you jump up from a full squat? You extend your back, right? You're going into this position. I'm doing it with my hands here, but going into a spinal extension pretty much, right? So he had some latent symptoms there. So then I ended up, I just look at him. I watched him walk, obviously, nothing really jumped out at me. Just, your sort of typical.
Mm-hmm.
I had him walk and take big steps, and you did see a little bit of wiggle wobble at the pelvis in the back, and it wasn't symptomatic basically, and I wasn't seeing a ton. I really wanted him to walk sideways, so for some reason I did that, and as I said, he was worse going to the left, side step to the left with the right knee pain. So then I went in and I looked at his quads. I said, let me just see if I can move your patella. So I'm on his left leg, the patella is nice and loose, it's like my little patella wiggle. I go in and I poke around the right knee, and I'm in the patella, and I can't move it. He's gripping that leg so hard. His quads were on fire, not unusual. Couldn't move the patella. I went in and, very rigid foot type, et cetera, et cetera. I tried to modify some positions at the foot to see if his body twist was better. And it was, but it wasn't jumping. It wasn't jumping out at me.
Mm-hmm.
So
like I'd expect it to, like, oh, that's it. When you do that, that's my pain. Oh, that kind of thing too.
Exactly. And I will tell you as an aside, just for the purposes of the podcast, because I'm not finished with the first session yet, but just so everybody can be thinking, the next visit, he's like, I wanted to talk to you about some elbow pain I had. And he's talking about and he's going in the ulnar distribution.
Is it on the right side or the left side?
On the left side.
On the left side.
On the left side.
Pain on the right side.
I think it's left side. Hang on, I'm looking at my notes here. Left elbow. And I did I did a quick assessment, but I just wanted to throw that out there before I go through finish the first. So he had, once again, had it for a while, not really bothering him until recently. So I'm like, well, you had to push off to get out of that egg roll position. There's something obviously got aggravated. So what I did was I in terms of like a basic assessment of people who know me, yes, his head was a little, I'll just do the straightforward center of mass thing that we talk about. He's fairly somewhat, honestly, a little bit to the right. So his head was a little bit shifted to the right. His thorax was a bit to the left, pelvis to the right. Once again, not crazy. His feet were gripping like crazy, both feet.
Pelvis to the right?
Pelvis to the right, thorax to the left, head to the right.
Mm-hmm.
Right knee flexed, bilateral gripping the feet,
trying to unload something in there.
Right?
I get the feeling that he's trying to unload something in there. Yeah. I don't know why. I just have that kind of feeling that this sounds just a bit more like, and remember, neurogenic can look like inflammatory. It can, we're fooled all the time. You should look at other parts of the body, not just the region. You should go look at the lumbar spine. You should look at the cervical spine.
Yes.
When you're looking at the arms, you should look at the thorax and the cervical spine. You should do that because of that. But it sounds like just this kind of thing with him is reluctance with his you know, his posture, you know, it almost sounds like, again, a stress response, you know, to what's going on with him. And he doesn't want to straighten the knee. So he's shortening up on that right side. Well, he's going to have to do something if he's short on the right. His thorax is going to pop out to the left, or else he's going to fall over.
Fall over.
Right. And then if your thorax pops out to the left, your head's going to go to the right to counterbalance it.
Exactly.
So it's like, okay, is this coming from the neck, thorax, back? Yeah, it's kind of there.
Yeah, his pelvis went with his leg and his foot, and you're absolutely right. Thorax, So it's interesting, and both of his feet, and you know what, Susan, it was very, and I made sure that he talked about this with his physician, because he actually didn't go in to see his physician. His right foot was mildly swollen. Not crazy, but you know, like you'll get some just swelling at the end of the day, and it was swollen versus the left. And I said, you know what, that's something, you know, to point out. And he was going to see his physician at some point. I said, you should mention that. Just, he has no cardiac history, nothing, you know, but it was a bit swollen. On the statins, exactly. And in terms of other issues, I had him do some back bending and side bending and forward bending. And, you know, he doesn't have a ton of movement. You know, forward bending, he was pretty stiff, tight hamstrings, the whole thing. It wasn't reproductive. Back bend, he could barely do it. I mean, I think that's so hard for people in his age group to do. And same with side bending. He didn't have a whole lot of options for movement in his lumbar spine, to be honest. And what clued me in, or what was really interesting, is that both sides, when he slept on his right and he slept on his left, his knee bothered him on both sides.
Yeah.
And that's always, for me, that raises like, why?
Yeah, more investigation needs to occur. The other thing that I just want to say here with the 1 foot and the cardiac history, I mean, his history may just be high cholesterol. Who knows what it is if you didn't ask him. And in that first visit, it's really hard to unpack that. One of the questions I would ask is about nighttime and sleeping. I'd like to know how many times this guy gets up in the middle of the night to go to the bathroom. Because that could be a sign of like either some rising hypertension at night, or, you know, I don't know. You don't want to think congestive heart failure right away, but, you know, you certainly want to think, why is his, you know, heart pump maybe not sufficient? And why is he swelling? Because this is an active guy. And you know, of course, his activity level has gotten so low because of the pain. You know, he's not as active as he should be, but you know, if it was that, then you would expect it to be in both feet. If it was just because he was inactive, like hanging, like sitting all day. Right. You know, 1 foot isn't going to swell more than the other. Usually they both swell a little bit. You get fluid in both legs. Yeah. One kind of starts making you think, what is that? Yeah. And it could be the neurogenic thing too. So I don't know. Interesting.
It is. And, you know,
he want to ignore for sure.
Yeah, it's funny because I did ask him about this, getting up in the middle of the night. He, you know, he's like once, twice. And I you know, went, okay, you know, but that's not atypical, I think, for him. But the swelling was something that raised a red flag for me, actually, just because it's not, I said, have you never noticed that before in your foot? He's like, oh, no. So anyway, so nothing, you know, suffice it to say, I looked at the knee. And, you know, rigid, you know, once again, you know, tib fem joint, a bit rigid. I did some PA glides there. I did the patellofemoral, did some PA glides there, just because I feel that he wanted me to look at that. So even if I don't think the knee's the issue, I'm doing that because they need to be felt and they need to be heard, right? These patients. So I did full flexion extension. Yeah, you know, basic PFJ assessment, tib fem, tib fib. Foot was as rigid as all get out, you know, no posterior glide in the talus. You know, couldn't reproduce any of his symptoms on the table. I did check a slump test. You know, very tight hamstrings, nothing crazy there. But once again, I do agree that it could be spinal or neural in nature. But I'm not going to.
His knee pain at all?
No.
Position?
No, the only thing that brought on his knee pain in the office was the body twist and the sideways walking.
Okay.
That's what brought it on.
So that he's going to have to be loaded a lot more to bring that on, which makes sense because the pain comes on with walking and not with sitting. Right. But I'm wondering, when you have a chance and you go back and see him again, I'm wondering if you just ask him to do the slump actively, see if he starts to deviate in his trunk.
In sitting or standing?
In sitting.
In sitting.
Yeah. I just want to see if he starts to like if he goes to lift his right, if he like shifts off to the left, you know, to kind of like accommodate.
Yep.
I don't know. It's just a thought, like kind of start, because, you know, he may have to be under more compression for that to happen, but
yes,
sometimes you can see those little things in, you know, just in those easy movements without.
Yep. I agree.
Pain coming on, but you see the beginning of the shift in the movement. And so that kind of just shows you that, oh, this thing is really getting caught up through the system and not just at the knee.
Yeah. Yeah. And it's interesting because I treated his wife on and off, and she said to him, he's like, you know, she thinks it's coming from my back. And I'm like, smart woman, because she has back problems, you know, and I was laughing so hard. So I've only seen him a few times, and I'll just sort of fast forward here because, you know, what I did was, because of the swelling, I actually gave him some we have this thing called Tubi Grip. It's like a thing that you wrap around your foot. And I've had them put it on his foot, on his right ankle, because I was like, you need to sort of, let's see if that takes that down. You know, I didn't give, he said, do you think I should wear a knee brace? I'm like, you can, it's not going to hurt. You certainly can if it makes you feel better. By all means, knock yourself out. I don't, you know, wouldn't suggest it, but if you have one, go for it. So when I saw him the second time, I actually, I rechecked everything. Okay. And that's when he mentioned the elbow issue. And I was like, here we go. I'm going down the rabbit hole. I cannot go down the rabbit hole because I need to, you know. So I did the radial. I did some upper limb tension testing. He was positive on an ulnar nerve glide, not on radial or medial, right? So I had him walk sideways again. It was still positive, no change there. I had him body twist to the right, mild symptoms. Body twist to the left, it was fine. So objectively, he was a bit better. There was no home exercise at all. I'd give him nothing to do the first visit except to put the Tubi Grip on his foot, and told him, and that's all I gave him, really. I didn't want to, I wanted to ruminate on this a little bit more. So, so I don't think it's a knee issue, a straight knee issue, you know. These are the kinds of, you know, if you have somebody that comes in with knee pain, you know, a lot of these patients get these squats and these active straight leg raises and the knee extensions. And, you know, this was the kind of patient who is in good shape. Okay. And he's not going to sit there and do a straight leg raise because it's ridiculous. It doesn't make any sense. There's no, you know, we always talk about what is the impairment, and the impairment, I'm not sure what the impairment is still. I think it's neural. You know, I don't think it's an impairment of a weak quad, or it could be an overactive quad, but that could be driven from, that's neural. That's a neural tension issue.
Yeah. And the other thing to think about too, I love what you're doing with the differentials here. The other thing to think about here is that central stenosis, or spinal stenosis, as you want to call it, now you can think central or lateral, doesn't matter to me, does not usually have back pain. In fact, you know, that's one of the big differentials for it in the, you know, when they're looking at injections and things like that, is like, you know, it rarely produces back pain.
Yeah.
But the movements, they do have a preference for flexion. You know, whether it's flexion on one side, you know, if it's lateral, or flexion for the whole system. And, you know, who's to say, you know, it looks like it might be one-sided, but it could still be coming from a central bias in the system. You know, and there's certainly places for him to get hung up. So that's why when I think, you know, when people are listening, I just want them to understand when you're saying that the impairment is neural, because it's neural somewhere. Where is it?
Right, exactly. Yeah.
It reminds me of a client that we talked about too, for me a while back, that his stuff started with knee pain, but it ended up being really bad pain in the back of his thigh. And it was definitely, you know, a central compression or a central stenosis up in his system. You know, and we spent a lot of time working to just loosen, you know, get his trunk moving as many ways as we could to relieve that pulling, you know, on the nerve in the back of the leg, for sure.
Yes, exactly. You know, and I think with him, his center of mass was still slightly right when I saw him. And I said, you know, you're loading that right side, you know, there's a lot of tone in the quad. You're still loading on that right. That's where your knee pain is. You know, there's something that's you're offloading on your left side. So I'm going to fast forward. I've only seen him a few times. Fast forward. I basically ended up giving him easy. So I had him go stand on a half foam roller because his feet were still so rigid. I didn't want to go down the rabbit hole of mobilizing foot or do anything to the knee because I still wasn't convinced that that was the problem. So I had him stand on a half foam roller and just do basic little squats, wall squats, facing the wall, hands on the wall, easy. And that he was able to do no problem. I mean, what patient who has really bad knee pain can do squats well? If you have a significant knee issue, you'd have a hard time with squats, and he was pretty okay.
Yeah.
So I would never have given that to him if it was a true knee issue, like if I felt the knee was the driver. And so he's like, yeah, this feels good. He's going down and up. That's what I gave him. The heels on the half foam roller, could have been on a book or on pillows for the listeners, if the patient doesn't have a half foam roller. And what I actually gave him I gave him basic ulnar nerve glides for his elbow. That's all I did. I was like, I can't, we need to sort of, they're probably related, but this is what we're going to do for this. I actually had him do the Recognize app for the knee as well, because I thought that would be very helpful. He's into all that, and he's a physicist.
Yeah,
so
kind of like shake up the right-left discrimination kind of thing, and maybe kind of take the pressure off of paying attention to that right side all the time. I think there's definite value in doing that, and it gets them to focus on other things, and it gets their brain crossing midline, which at all of our ages, we need to be crossing midline, whether it's practice or performance.
Yep.
And some of the research that's coming out even more and more is that the practice, the performance practice is probably more important for brain changing than the actual performance itself.
Yeah.
So, those kinds of things are so, especially somebody active like that, I think that's just really great and important.
Yeah. And also I forgot to mention that when I had him walk on his heels, he was worse. When I had him walk on his toes, he was better.
Yeah, that makes sense.
Bingo, right?
Yeah.
So, you don't want to go down. The reason why I wanted to talk about him is we don't want to go down the rabbit hole of, the knee, because it conceivably could have been that way, right? But little bits of his story, like the side lying, the fact that he was okay in the morning, the sideways, the heel of toe walking, what's the word I'm looking for? That's not a lot of spots for the knee column. We have columns that doesn't go in that category for me.
That is not getting checked off under that part.
Exactly. So, and for me, I saw him the last time just before the holidays, and his center of mass is getting better. And I kind of look at that just for my own self-check. He was loading his limb less, and I think that was improving, and he actually was feeling better. And so I gave him little wall squats, the Recognize app, the ulnar nerve glides. And when I had him walk, I said, I want you to arm swing. I want you to cross midline when you walk. That's all I gave him.
Rotation for the arm, the neck, the back, the leg. And this is the reason that we're kind of thinking like this is because you can find stuff in this guy's knee. So you can validate your conformational bias, and you can find all kinds of stuff in his knee. But is that the driver of his pain? Right. Is his pain being expressed because somewhere else in the system has gotten sensitized?
Yeah.
That's what the key here to this was. This is great. Thank you for sharing this. It's a great story, and it kind of brings home a lot of stuff that we think about in the textbook, but this is like a kind of, they all present differently in the clinic, and being able to kind of grab those things and look at them in a different way can help us kind of step back and get a little bit of a bigger picture. We may not know the answers of why, but we know that it's not there. What else can we do to influence the system and then begin to bring it down and change it?
Yep, absolutely. Just pick up on little clues. Those will be your keys. Awesome. I hope everybody enjoyed it. I certainly did.
Okay.
We'll see you on the next podcast. Thanks, everybody.
Right. Bye, everyone.
Bye.